Okay. So bottom line, I live in Phoenix, Arizona, and I spend a lot of my time these days working with learning healthcare systems, which is where we're going to end, and I hope we get a chance to talk about it and you ask me about it. A number of disclosures, which I'm OCD about disclosures, none relevant to today, really. And so the question is, why are we going to talk about this? This is hard. Compared to the grief session we just had, there's some jokes over there. Brad is a funny guy. We don't have any of this here. But the reason that I feel comfortable doing it is because I already know your lives are hard. This is not a new domain for you. Why? First of all, when talking about mortality, it's your right to know. Can you imagine getting a diagnosis yourself or a loved one of cancer and going to a care provider and not talking about mortality? Would that occur? Absolutely not. Would you leave the office satisfied? You'd want to know, am I going to die? What's the likelihood of this happening? And so the right to know issue is sort of a big deal. And whereas the oncologists, part of their everyday life in neurology and epilepsy, we have a generation of folks, that'd be me, who tend to be paternalistic and maternalistic. We know what's best for you because if we give you this information, you're going to be depressed and anxious, and so we think it's best not to provide this information. That is old think. In the last decade or so, it started to change. And because we have to. It's the right thing to do. Part of knowing about risk is motivation to pursue aggressive therapies. And it changes the way you think. If someone says to you, well, it's likely your child's going to, grow out of their seizures. Versus, there is a chance of death. And it's in the office. When I'm in the office, it's because I'm on the other side of it now. I'm pretty aggressive about pushing families to do more and more things, which doesn't always go well, by the way. And finally, preparing for the future. Whether you're 2 years old or 80 years old, having that hard conversation and asking the what-if question, it's terrible. However, it is so much better, and this is from families who've lost loved ones. If a physician has never mentioned the possibility of mortality, and it happens, it's something that families never get over. And I've just heard it more often than I even want to think about. So that's why it's important that we have this conversation. So the sort of the order of things, talk generally about mortality and epilepsy, introduce you to the concept of sudden unexpected death in epilepsy, SUDEP, talk about mortality in children with epilepsy, LGS, and end with prevention. So that's sort of the outline. Okay, it's hard to put together because LGS is complicated, and I mean that's the theme that we heard from the first lecture. Dr. Berg, who speaks much better than I do, had that great slide of the nut and the nutcracker. It's a tough nut to crack. It is, and because LGS is not one thing, you can't go through and say, oh, here are all the risks for this one thing. It's as you know, it's many, many things. So what I'm going to do is try and just walk you through it. And all these slides, I send them to Tracy, and they're yours. And so this is sort of the outline to approach mortality in these groups of people, just to drill down on it a little bit more. So I don't believe in dumbing things down, mainly because families are smart and they want to know what their doctors know. So I'm going to show you sort of what I would show a professional audience and do some interpretation along the way. That's the strategy. And if there's something that's unclear, just raise your hand and say something subtle, like, what are you talking about? I respond to instructions. And so, and the other thing I want you to notice is that most of this literature is relatively recent. This isn't from the olden days. So this was an important study from 2017, the burden of premature mortality of epilepsy in high-income countries. So, premature mortality means before you'd have a natural death. And high income is because it's a very different picture if you're in sub-Saharan Africa than the blessings that we have. The bottom line from this very, very important and detailed study was, for those living with epilepsy, the risk of dying prematurely is 1.7 to 7.5 times greater than the general population. So that's a fairly significant number. If you talk about doubling your risk for something, that gets your attention. But this says 7.5, and we're going to go back to this and see that that's actually a conservative number in some populations. When does it occur? So this is age, and this is the increased risk of premature mortality, death. And what you see in the box that I've highlighted is that the highest risk is at the earliest ages. That's us. That's LGS. That's my practice. So, and look at the numbers here. We talked about 7.5. We have something as high as almost 9. So this is something that we have to pay attention to early in life. And this is another way of looking at sort of the same thing. When does it occur? Years since epilepsy diagnosis. This is 5 years old right here. And look at the big numbers here. And
Is that all? It says all mortality. That's not just SUDEP, right? That could be accidents too.
yes, all mortality. And thank you, because what I'm going to do in just a slide or two is separate those things out. And that has implications for prevention, because, I got to get a new gig. I want to be Tony Atkins. I have the bow ties. I want to make people happy.
But can't you bust a move?
After the beers for the dog and the kids? Yes. Yes. But that's a very important point, and we'll get to it in just a second. Okay. Now, this is also from the same big survey, and these are the studies, comorbid conditions, and the risk that these impart. Yellow box. Look at the first one, encephalopathy. Look at the numbers, 25, 12.8, 22, 50. These are all much bigger numbers than 1.7 to 7.5. So having a comorbid encephalopathy increases risk very significantly. Mental retardation, cerebral palsy, same thing. Almost double the risk of having a brain tumor. Okay, so this is regrettably where we're living. Now, you just heard that includes all deaths related to epilepsy. Now I want to define a single type, and this is sudden unexpected death in epilepsy. And it was defined in 1997 by two researchers as a sudden unexpected non-traumatic death in a person with epilepsy without post-mortem autopsy evidence of a structural or toxicological cause of death. So if you had a brain tumor or something, that's unlikely to be a SUDEP. And there's different, classes based on the level of evidence. So that was SUDEP in 1997. Subsequently, people said, that's not complete. That's not enough definition to do research, which we must do. And, there's some other ways to think about SUDEP. For example, suffocation. A lot of individuals are found face down in a pillow, and those were considered not SUDEP because it was suffocation, except that there's now evidence that they would have a seizure, turn over, and that's how the passing was. So that's included. Same thing for drowning. People going out and drowning, that wasn't SUDEP in 97. In 2012, if there's not water in the lungs, that may be because there was a seizure and drowning while in the water. So dry drowning. Anyway, so this is the more modern definition, the key features. Now, the question was, how often does this occur? And I got to say, if you had a look, this meeting was populated by two classes of fantastic scientists. One is people like Dr. Ann Berg, who's an epidemiologist, and the other people like Dr. Sheffer and Dr. Mefford, who are geneticists. And those fields have contributed mightily to this literature. When we looked at this in the American Academy of Neurology, 2017, what it looked like was the risk in adults was 1 in 1,000 person years. The risk in children was 1 in 4,000. That's what the literature told us. In fact, there was additional information that was published 3 months after this paper came out that said the incidence in children less than 16 is virtually identical to adults. So that, and this is just 3 years ago, 2 years ago, and that changed the way that neurology looked at SUDEP. This is a problem that involves children. This was a study that was published recently, 2018, from Canada, my colleague Elizabeth Donner and her group, and they did a very detailed study of SUDEP in Ontario, Canada, and they used a variety of methods. Now, one of the barriers to understanding how often SUDEP occurs is that there isn't a code for it. How do you find stuff? There's a code. There is a code for Lennox-Gastaut. Hooray. So we have that data, but this was hard to come by. And they found 17 occurrences, and basically their data was the same. So children and adults have the same incidence, and you see it's in the range of 1 to 1.5 occurrences per 1,000 patient years. So that's like real data now. Now you say, well, gee, actually let me do this. It's out of order.
What do you mean when you say 1,000 patient years?
If you followed 1,000 patients for 1 year, one person would die. Yeah. Thanks for asking. When SUDEP hit the scene about a decade ago, there was a flurry of misinformation on the internet with 50,000 occurrences per year. And those of us in that domain said, that doesn't sound right. So again, an epidemiologist looked at the real data, and Dr. David Thurman found that in the United States, all epilepsy deaths, about 6,000 per year. But look over here. The major cause, the red bar, Sudep. And for most neurologists that haven't been in residencies in the last 5 years, this is news. We never talked about it because it didn't occur. But then you say, okay, we're talking, not even 3,000 cases per year. How big a deal is that in the scheme of things? And the answer was, when Dr. Thurman looked at the information and looked at it in terms of annual years of potential life lost, there was stroke, number one, because that's very, very common, but Sudep was number two. And that's because it afflicts a younger population. And I realize how terrible this is to you in this room. But you need to know the facts to prevent and advocate for prevention. Okay, just two more facts about Sudep. Number one, it's related to the number of generalized tonic-clonic seizures. And in some settings, people gasp when you say, oh, look, by having more than 50 seizures a year, it increases the risk 23 times. People with Lennox-Gastaut have thousands of seizures. This is like, you're kidding me. Who cares about 23 seizures or 50 or greater than 3? It's like, but again, my last slide is on prevention and being aggressive about seizure reduction. And okay, 0, may not be possible, but the smaller the number, the lower the risk. And that's what it's about. Another little factoid about Sudep. It occurs 60 to 70% of the time during sleep. Some of the slides I took out of here, this slide set, because we all have to go home sometime, basically drew the connection between seizures occurring during sleep in Sudep, motor seizures, and LGS, which is defined by tonic seizures occurring during sleep. So, high-risk group. Okay. Now, moving on, looking at risk. These are just studies, and this is the risk, again, patients per 1,000 years. And these higher risk numbers, where are they? Refractory epilepsy cohorts, epilepsy surgery candidates. Down here, general population, it's not a huge issue. For the LGS population, it is. A couple of years ago, Elizabeth and a number of us got together to try and put something together to understand death in children with epilepsy. And so here's the answers to your question. So this is all deaths, 5 to 10 times the general population, from 1, 2, 3, 4 studies. There were epilepsy-related deaths. This is the open bar, the white bar. Status, aspiration, Sudep. Non-epilepsy-related deaths. the underlying neurologic problem, a neurodegenerative disorder, a brain tumor, pneumonia, not related to seizures. And what you can see here is that when talking about mortality, the big bar is not related to seizures. Big point, because, as you'll see, there's some preventable things in here. You know, knowing we can't control everything, but you go for the things where you can have intervention. Now, this is causes of these non-epilepsy related deaths. And the big red bar in all of these studies is pneumonia. And what you're going to see is, if I go through the presentation, is, you know, when you see something once, when you see something twice, you see it a couple of times from different places in different countries, you got to pay attention. And so we got to pay attention over here. What about epilepsy-related deaths? And again, the big red bar is Sudep. Across 4 studies. There's status, there's aspiration, but the number one thing is Sudep. Yes, ma'am.
So in this community, pneumonia doesn't even show up as cause of death? Did I misread that? If you go back one? Because
So this is epilepsy-related deaths.
okay.
Pneumonia was on the non-epilepsy, the number on the non-epilepsy, yeah.
But it includes non-epilepsy related, but people who have epilepsy.
Yes, yes. Yeah, it's not a population, it's children with epilepsy, basically, yeah.
So a pneumonia death would not be considered SUDEP?
Correct.
Even though it's secondary to probably having epilepsy?
So the way that would be parsed is if you knew someone had a seizure, they aspirated and got pneumonia, that would move it into the seizure-related kind of thing. And then when you're doing research, you have you have to have some definitions. What if that happened? What if there's a seizure, aspiration, pneumonia, and then 3 weeks later the person died of pneumonia? How would you what would you call that?
Or the reason that you're getting pneumonia is because of the side effects or the secondary diagnoses from the epilepsy?
I'm not sure what you mean.
I guess, so for instance, my daughter has seizures which cause her to not develop and not remember how to swallow. She's then more at risk for aspirating just
Yes.
food or spit, and then she gets pneumonia. So the pneumonia is because of her device.
Yeah, that's that'd be a combo, which that's how we started. But that bucket would be non-epilepsy related, and then if we wanted to split it further, it would be, is it due to the underlying disorder or to the pneumonia which was the result of it? And the problem is, we can do that, but the problem is when you start dividing and dividing and dividing, you get so few people in each little bucket that it gets harder and harder to make sense. So that's why scientists kind of put them together. Yeah, but no, that's a great point. Okay. So now another concept. In the old literature, which many people still think about, there's sort of 2 buckets. People with seizures of unknown cause, so-called idiopathic, many of which are not, they're genetic, and the group called secondary or symptomatic. There was a stroke, there was an aspiration, there was brain trauma, something happened. And a lot of the older literature is defined by symptomatic versus idiopathic. This was from 1993 in Victoria, Australia, and it looked at causes of death, and the bottom line here is that 94% of that population were in that secondary symptomatic group. And so in the olden days, one of the groups that LGS would be put into would be secondary or symptomatic. This is a unique study that I want to share with you because there's not a lot like it. This is a prospective study based on a population with 40 years follow-up. You know, that doesn't exist in the States. This is from Finland, and it followed kids that were diagnosed with epilepsy since 1994 and then followed them for 40 years. Wow, you know, what happened? So to be clear, this is childhood onset epilepsy, but not child mortality, because most of these are adults. And and I'm going to run through it quickly. There were a total of 60 deaths. 45 of the 60 were symptomatic, just like we've talked about. Something you knew happened to the brain. 85% were not in remission. They were actively having seizures. Is that all right? Yep. Deaths related to epilepsy, 55. Deaths not related to epilepsy, 43. The deaths related to epilepsy were overwhelmingly Sudep. The deaths related to not epilepsy were overwhelmingly pneumonia. So we see it again from Finland. And this was a paper that was published 2013 from that group where they reanalyzed the data. And now we're moving into, you know, I looked, where can I find LGS? I found it here. Okay? So this is that same study. There were 4 patients in that group, almost 7% of the total number. Cause of death of those 4, 3 of them were Sudep. This is something that Dr. Berg authored in 2004. Again, mortality in childhood onset epilepsy, factors associated with mortality, epileptic encephalopathy, again, part of the group that LGS fits into. And in Ann's paper, this meant LGS West, and it was, I think, just before Otahara. And what you see is that it was 15%, and the number 10, it was actually the largest category. This is from 2013, where Dr. Berg and others combined 4 populations. And part of the brilliance of Ann Berg is that she makes complicated stuff simple. And she divided the groups into complicated epilepsy and uncomplicated. And complicated was if you had an abnormal exam, intellectual disability, or a structural cause on MRI. And what she found, the risk of death was 20 times greater in complicated than uncomplicated. And this was the group that she combined as one. So this is a very recent paper from 2019, and there's this whole thing called systematic reviews, where people look at the literature in a very formal way. There's a whole science to it. And the intent is for you not to read this, but just to say they started with 590 papers, ended up with 22 that were good enough to get data from. From those 22 papers, there were a total of 108 deaths, which for Sudep, which those of us in the community know has to be way wrong, but that's what they found, reported. And it was just 108. This is some of what they found in those 108 individuals. And again, symptomatic cause is right up there. But look over here. 25% were 5 years of old or less, small children. Over here, Lennox-Gastaut, there were 5. And we know that has to be a wrong number, but that's what they found. One of the other things that I want to just bring to your attention, because epilepsy, we have a big umbrella, is that we tend to think of SUDEP in the most impaired and the greatest number of seizures. It's also true that it happens in the so-called benign epilepsies. And so this is changing the thinking of pediatric neurologists and epileptologists. And I guarantee you, we don't like it. So when you feel pushback in the office, that's part of the reason.
Could you define benign epilepsy for me?
So this is the concept of a benign epilepsy, which I don't like, and Anne doesn't like either. What benign epilepsy has been in the past is something that is self-limited, means that it goes away, there are relatively few seizures, and it responds to medication. And so that was the concept. But the problem with the concept is that when you collect data, it's wrong. How can you have a benign epilepsy where people die at the same rate they do with Lennox-Gastaut syndrome? Okay, and just to say that you folks are sort of on the cutting edge of pediatric epilepsy. You know, you're exposed to stuff because you're here that a lot of folks in the community just don't know. So, you know, probably if your neurologists have issue with the word benign, refer them to me. Don't duke it out because they don't know about it. Not because they're bad people, they're just not on the edge. Okay. Now, this was a paper from the Mayo Clinic that looked at patients greater than 18 years of age with late onset Lennox-Gastaut. And they identified 10 patients, you know, in that group. Of that 10, there was 1 SUDEP. 10%. That's still a big number. Late onset Lennox-Gastaut syndrome. This is a paper published from Canada in 2007, which population-based, 20-year follow-up. You know what symptomatic generalized epilepsy means now. That's that complicated group that Anne referred to. At the end of the study period, 21% of the individuals with symptomatic generalized epilepsy had the Lennox-Gastaut syndrome, which wasn't something that was known. 19 patients passed away, all with intellectual disabilities, 25% of those with LGS. So whether it's 10% or 25%, it's a big number and too big a number. This is again from another country, and now I'm actually reviewing the world's literature with LGS for you. There isn't that much of it, although you may think it's going on and on. It's going to come to an end very quickly. And again, over this period of time, 4 SUDEPs were identified, 25% of the SUDEPs, LGS. Now, we're now going to take the next step, because part of what everyone wants to know is, what about me? What about my child? You know, population stuff is great, but how does it relate to me? And that's where the explosion in genetics is going to be so important for so many reasons. The importance of having a diagnosis. So as you've seen, there isn't a huge literature on mortality in SUDEP in LGS. So one has to look for things that are connected to LGS, one of which is the SCN1A variation of Dravet syndrome. So let's look there. This was a paper put together by Dr. Sheffer's group in Australia, where she looked at, and her group looked at 100 consecutive patients enrolled in this project, and really from around the world. About 3/4 from Australia, the others from around the world. And 87 had the mutation, 17 passed, 10 due to SUDEP for status, and there was no relationship to the nature of the mutation, the age, development, or MRI. They calculated a mortality rate of 15.85 per 1,000. So you remember that first slide, 1.7 to 7.5? This is almost 16. Now, is this great epidemiology? No, because the other stuff was population-based. This was, you know, when you connect with Ingrid Sheffer, something's going on. So this is an ascertainment bias issue. But the point is that the rate among SCN1A is pretty high. And the point they made was Dravet specific. After correcting for a number of things, 9.3, epilepsy total population incidence 1 to 1.5, refractory around 5. This was another review of the literature, and I'm just showing this to hammer home the point that in Dravet syndrome, the lion's share of the passings are due to SUDEP. And when do they occur? This is birth, this is 20, and here's where they are. SCN8A, and a relatively recent paper, 2018, 10 passings, 4 due to SUDEP, 5 to respiratory failure. So this is a, you know, how do you wrap your head around this? On the one hand, we're being finer and finer with diagnoses for all the reasons that you've heard. On the other hand, any way we slice it, the deaths are largely due to SUDEP, pneumonia, and status. Okay, so almost the end, because I don't think you can take any more. I can't. I get to see all your faces, and this is... Okay, prevention. The first is, you know, from what you've seen, the early diagnosis and treatment of pneumonia. And, you know, sometimes you don't want to overtreat infections because of antibiotic resistance and all those kinds of reasons. But if you or a loved one have respiratory compromise from an underlying problem and there's a little fever and a little sniffle, get on it. Straightforward, important, impact. Identify the cause. You know, there's more specific therapies available all the time. You've heard it from Dr. Sheffer. We just heard it from Dr. Mefford. You know, this is happening. And so the importance of identifying the cause can't be underestimated. We've talked a lot about genetics, but you saw in one of Dr. Sheffer's slides, I think, that 25% or 30% of LGS is structural. Whenever I hear structural or see an abnormal MRI, I think epilepsy surgery. Epilepsy surgery can be curative. We don't do it enough in this country. for all the reasons that, people are afraid. But it's a big ticket item. And what if you could cure 1/3 of LGS with surgery? Phenomenal. Same thing with ketogenic diet. We don't use these things enough that are available. So that's my little bandwagon there. Oh, not yet. Reduce seizures to minimum via aggressive therapies. What is the evidence? There is evidence for medication, surgery, and vagus nerve stimulation reduces SUDEP and reduces mortality. There's real evidence, which I'm not boring you with. There is no evidence for ketogenic diet that it reduces mortality, but I can tell you it reduces seizures in some of the most refractory kids that I've treated over the years that are not candidates for surgery. Nocturnal supervision. There is some evidence, not a lot, but some, that knowing when someone is having a seizure and going into rescue can make a difference. Now, the thing, so that's why I'm big on everyone learning CPR and having, that kind of thing. What I got to tell you is there's also evidence that says you can't rescue everybody. And so some folks have died in the hospital with CPR by medical professionals. But it's, I think, a good thing to know. Seizure warning devices. There is no evidence that these reduce SUDEP. We think they help us, find seizures, but just to be, formal, there's no evidence it reduces SUDEP, not to say it's not a good idea. And finally, this is how you know it's the end, almost. Epilepsy learning healthcare systems. So you heard Dr. Greenspan mention it briefly. So what are these things? You're cutting edge now. This is something that's only existed the last year and a half. You know how in the first day or so we heard about all those things that have been tried in LGS? And some worked, some didn't. There were no studies. And we heard about using Seizure Tracker or My Seizure Diary to get all the data in. It's not going to work. And the reason it's not going to work is because if everybody's doing things differently and calling things something different, you can't make sense of the data. Learning healthcare systems is a way of addressing this issue. These are networks of places that work together to collect information in a standardized fashion with regard to diagnosis, to treatment, how we treat people, referral to comprehensive epilepsy centers, and transition. This is an enormous effort. But without learning healthcare systems, we are not going to adequately address the important issues in LGS. And so this is my little bandwagon to get on your healthcare providers to say, are you a member of a learning healthcare system in epilepsy? They'll look at you, because remember, you're on the edge. And then you can refer them to the Epilepsy Foundation, type in learning healthcare systems, and you can read about it. The press release was a couple of days ago in Philadelphia. That's how new it is to the public. Okay?
On the point that seizure warning devices, there's no evidence that it prevents it, are you saying there's no intervention whatsoever for this? I mean, because if you're
No.
warning-
No.
Well, what is it? I mean,
Okay, so I'm a formal guy because I have a bow tie and this. And what I mean here is if you or one of my colleagues pushes me up against the wall and says, Jeff, show me the proof that medicine reduces the incidence of SUDEP, what am I going to show you? I can show you a study. Same thing for surgery, same thing for VNS. Do I believe the ketogenic diet saves lives? Absolutely. Can I show you the evidence? No. So that's the difference. Okay. Now, yes, sir.
Yeah, I guess sometimes, the problem with clinical evidence is that you're testing just one aspect of it, not the combination and synergies between different interventions. So, we have to be careful discounting certain benefit, for instance, the ketogenic diet with medicine, for instance, with, supervision, etc.
Yeah, and I think it's an excellent point. It goes back to the second slide. It's complicated, and we walk this line between we want to get evidence out there sooner rather than later, but in order to do tightly controlled, randomized controlled trials is a much bigger and expensive deal. I want to end with one slide, and then we'll do questions. So, if you haven't read this book, and you have an evening when you haven't cried yet that day, which I know is a big issue for a lot of people in this room, The Power of the Powerless. This was written by a high school teacher who really wanted to be a journalist about his brother in rural Maine. And so it's a biography of the brother, the family, and the community. The point of the book is the title, the great power and impact and joy that this neurologically completely disabled young man, little boy and a young man, had in the world. I don't think we can forget to say that, often enough, because, you're slogging through it. It's hard, but your loved ones are of tremendous value and power. So with that, I thank you. Yeah.